now is I'll just give a quick introduction to Joey and Paul. And if you haven't seen Joey and Paul before, it's a great session. This is a different one to we've done before. Very interactive from the pair of them. So Joey and Paul are co-founders of Framework Genie. They're based in Birmingham, and they're company specialists in compliance, information governance, and helping entrepreneurs and businesses stand out and expand into new markets. There's just some of the stuff they've done, and we had them on before in our series at the beginning of the year in our I'll call it the summer episodes. Going to hand over to Joey and Paul to take the reins from now. And any questions, please put into the chat. And thanks very much. Here you go. Over to you two.
Thank you. Hi, everyone. And thanks, Andy, for that wonderful introduction. So our agenda for today. I'm Joey Islam, co-founder of Framework Genie. We hope you find this interesting. AI is such a big topic. What we're going to do is try and skim across the majority of it. So if you need to speak to us in more detail, we'll come back to it. But we're trying to cover this in the 45 minutes. So our agenda for today is adoption. So how does healthcare face hurdles in adopting new tech? Ethical and regulatory issues, particularly in AI. So how is it responsible, and what are the evolving policies? It's a bit like the Wild West in regulatory world at the moment. And the final one, especially in the NHS, is readiness and evidence evaluation. So, Paul, do you want to introduce yourself?
Hi, it's Paul Moran, also a co-founder with Joey. We've been working on compliance for some time now, and we're looking forward to walking you through the journey today. So,
okay.
Sorry, Joey, go on.
I was going to say, let's just go to the next slide. Why does AI matter to the NHS? Paul, can you just give us an idea of some of the situations there?
Sure. I think you'll probably all be aware there's rising demand and workforce pressures. Staff are stretched. There's increasing diagnostic backlogs and variations in the access across the country to services. And I think this is where AI can support safer, faster decision making when it's properly assured. It's important to know that AI itself won't replace clinicians. It strengthens the workflow where pressure is the highest, really, is what it's about. And you can see from the slide, there's various other numbers and such like, staff support, and the amount of money that's committed to this is quite significant over the next 4 years. Well, there's a lot to tidy up, I think, with a lot of inefficiency within the NHS itself. Anyway, enough for me on that subject. We've got plenty to cover.
Let's move on to our next slide. We think this is quite apt, actually, especially in the use of AI. The expectation of what it can do versus the reality of what today is in the NHS. So most teams, when they develop AI, focus entirely on its accuracy. So hence, is its algorithm, does it work? We assume the model is smart and the test results are good. So the NHS will just buy it based on that. What do you think, Paul?
Well, that will be the expectation, I think, but the reality is that the accuracy is just the start. To actually deploy, you have to survive 4 specific reality checks. Yeah.
So what are those?
Well, the first would be the integration with clinical workflows. You may well have 99% accuracy, for example, but if you add extra clicks to a busy doctor's workflow, potentially you're going to shoot yourself in the foot, potentially. Second is demonstrating effectiveness. It's not enough to show that AI works technically. You have to actually prove it actually improves patient outcomes or saves money.
Oh, okay. So now it's fit the job and proven its worth.
Yeah.
What about the cultural stuff?
Yeah, and that's another hurdle, Joey, really. That's the information governance. Startups, in our experience, have often seen information governance, or IG, as paperwork. But NHS staff have, in some cases, deep IG anxiety, having spoken to clinical staff, and we found that that's the case. They often work under strict liability rules, and if you don't prove you are safe, you just simply won't be bought.
And And what's that fourth one there?
Yeah, the procurement gap. The clinician sees a patient to treat, I think, but procurement really see it as a risk integration costs, and 50, many other departments, perhaps 50 to, I don't know, whatever, fighting for the same budget. You can't just sell to the doctor. You've got to arm them with the evidence to convince the people holding the checkbook that it's good to go. So that's important.
So
Oh,
for any of us who've lived in London and used the Underground, our key theme is Mind the Gap.
yeah,
So these three gaps appear pretty much across the entire estate of the NHS in the UK. Paul, can you
yeah,
just take us through what they are?
yeah. You'll need alignment across adoption and clinical workflows, ethical use, AI, and regulation and safety. If even one is weak, then deployment is likely to stall. So
So in the famous lyrics of the Virtue, we fall into the first gap, and
yeah,
that is adoption in clinical workflows. Can you give me a real world example so we can bring this to life in the webinar?
yeah. I think what we've got really is an AI pilot that was done for radiology in Southwest London. They ran a chest X-ray model across two different sites for 2 years. Um,
2 years?
yeah,
A chest X-ray. So is it a bot? I bet they just tested it to see if it was smarter than the doctors.
well, that was the site A, I guess, of the two sites that they did this with. So they did a direct comparison, AI versus the radiologist, and they wanted to prove accuracy and reliability. And yes, the model worked, but that wasn't enough to get it adopted, unfortunately.
So, well, why not? If it works and it's accurate, all I want to do is sell my product. So why didn't they just sell it?
Well, because of site B, the other part of it, they didn't focus on the code, they focused on the workflow. And they asked, does this actually make the day efficient? Does it help the patient flow? Yeah,
Ah, that famous so what factor.
exactly. So the pilot showed that shared governance, getting the teams to agree on how to use the tool safely, was just as important as the tool itself. So
So I can have the smartest AI in the world.
yeah, you could, but if it breaks the hospital's workflow, it probably will stay on the shelf. Accuracy will get you interest, but workflow will get you adoption. Yeah, I think is what
Okay,
we
so
see.
so given the interest of time, we'll go across and just look at what's practical for someone who isn't working in a hospital, developing some tech on the outside. What's the checklist that we could take them through
Uh, right.
without wasting the 2 years that those guys did? Well, maybe.
Yeah, yeah. Well, paradoxically, you speed up by slowing down, I think. Excuse me. You need to tick these four boxes on the slide here, really, before you even think about going live. Yeah.
Okay.
And yeah, and I think the first one is select a single partner. Don't try to sell to the whole NHS at once. Find one trust that really has the problem, and you solve it and make them your champion. I think is one of the messaging. Really, don't overcommit to doing stuff with the NHS. Focus on one
Okay.
single partner if you can.
So find a partner. Can we just plug it in now?
Not quite, no. You still need to map the workflow. You're literally walking the floor, if you like. If your AI adds even more than a few extra clicks to the doctor's day, as we mentioned, the likelihood is that it won't be popular. You have to fit to their processes, not the other way around. So you really do have to take the time to map that workflow.
Okay. We don't annoy the doctors that come on side. So what about our tech? What's the checklist for adoption in our tech?
I think that's probably reviewing data structure would be step three here. Never assume that the NHS data is clean. You're probably aware of this, but ask for a sample extract early. If you build your whole system, assuming perfect data, then you'll break it on day one. Very important to get the data structure and the information around that out.
Okay, and the last one then.
Yeah, this is really test and monitor, which is run in parallel. Don't switch off the old way immediately. You need to prove with logs that your tool is safe and stable before you take the training wheels off. Very important.
Thanks for that, Paul.
So
So that's covering our first gap. So if we move on and look at what our second gap is, it's ethics. So isn't ethics, well, as the Google guy said, just don't be evil and do the right thing. Should we move on and cover, what ethics is?
yeah, sure. I mean, if only, ethics really isn't just philosophy. It's sort of engineering in a way. You have three specific hurdles here. The first is bias. Does it work for everybody or just the demographic you trained it on? Second is explainability. Can a doctor, for example, explain why the AI made that decision is important? And the third really is the GDPR gap. And we'll come to that in a second in more detail. But if your AI makes decisions without a human in the loop, I think you might be breaking the law. So that, there is a case study, and we'll go through that now. I think that probably will help Joey. So we move on to that other slide, or next slide.
Okay, so ethics. Should we look at so this case study is probably the largest example we could find. Paul, do you just want to take us through this one?
Yeah, so really this was Foresight AI, which ran in 23-24. It used circa 57 million de-identified patient records inside the NHS secure data environment.
So 57, isn't that the population we've got in the
well,
UK?
yeah, probably not far off, I don't think, these days, probably, yeah. But yeah, it does sound like a privacy
Isn't that a
nightmare.
nightmare in privacy then, having that many people?
Well, exactly. Yeah, it does sound like a privacy nightmare, but with the strategic data environment, secure data environment, the data never left the vault. The scale allowed them to ensure that they had fairness across the population, I guess, checking the model worked for everyone in the UK. Not just a small sample, and they wrapped that in a responsible governance with strict, guidelines, transparent controls, so everybody knew the rules effectively. So a very, very big, comprehensive study.
Okay, so let's say we're not a research team and we don't have access to the University of Birmingham's infrastructure, and let's say we're not a clinician, but we have an idea and we would really want to get through this process. So what can we do practically to prepare to present good ethical data demonstration that our product is ethical?
Sure. So really, it's about testing fairness, testing predictability, defining the boundaries, and use things like tools like the algorithmic impact assessment tools. Use those earlier on if you can.
Who's that? Sorry, Paul. Who is the algorithm? What is that?
Well, yeah, there's for example, there's the Ada Lovelace Institute. They have a product which you can use to assess the impact of your AI, and it's always worth doing that. It's not a legal requirement to do it when you're going through the NHS rules, but it is expected to have that done. So that will inform whatever else you're doing as well. So it's a very, very good thing to do, and do that early on if you can. And the NHS teams themselves want confidence that your AI behaves safely, consistently, I guess, and but that's across all the population they serve, I might add. But start by identifying all relevant user and patient groups to ensure inclusivity in the project, I think, is key. So testing fairness and predictability across key subgroups and workflows to detect any biases or failures is important. Document all the boundaries, that there aren't exclusions clearly, leveraging those tools I mentioned before, the impact assessment tools, and create a transparent explainability narrative that you will need to build trust with the purchasers.
That's the bit where the doctor can explain the decision that the AI took. I understand. So right now, from our experience, we've got AI in health and care is mainly used to support decisions, but not make them. clinicians still make that final call. So we found some automated systems exist, like staff rostering, which is quite a useful tool, but not for clinical decisions that affect patients. But there's always a sting in the tail, isn't there?
Yeah, yeah. I mean, under GDPR, people have the right not to be subject to a fully automated decision that has a legal and significant effect on them. So if AI is ever making an important decision, a human must be able to step in effectively, and a review has to be meaningful and not just a tick box formality type thing. You must document the human in the loop process, if you like. So if the computer says no and the doctor just clicks OK without thinking, for example, that is not meaningful. It's not a meaningful human review, and that potentially is a compliance breach waiting to happen.
Yeah. So we have to show that a human, a trained clinician or someone appropriate, has reviewed the decisions provided by the AI and supported it. Okay.
Yeah.
So
absolutely.
That's what we've got to do, even if we've not got access to the secure data environment. We have to go through this checklist. Got it. So let's go on through our final and perhaps generally the largest gap, which is regulation.
Yeah.
Okay.
So what have we got for regulation?
So I think, Paul, we broke this down into some practical steps. So again, if we don't have access to a whole bunch of stuff that's funded or part of a larger organization, what can we do? We know that selling AI in the NHS, we know this feels like a bit like a maze. You've got the tech, but actually, where do you then start in the sales process?
Yeah, where do you start? Effectively, I mean, it's not just about selling, Joey. It's a journey. It's a regulatory journey. We'll break it down into three clear stages here, really. First one is the foundation, if you like. You need to figure out exactly what you are, legally speaking. For example, are you a medical device? If you get this wrong, nothing else matters. It's very, very important. Stage two is compliance, really, in terms of knowing your regulator. It's called, we call this the ticket to play, if you like. This is where you tackle things like data security, clinical safety standards, something called DTAC. You'll probably come across digital technology assessment criteria, which is like the NHS baseline standards. You just need these really to get going, to open the door before you move forward. And then you really then got to go into the evidence life cycle, really. Once you're in, how do you prove the value to get paid, effectively? How do you stay compliant without getting kicked out? Staying compliant is really important. So we do need to go into this in a bit more detail. I think, Joey, perhaps we can go to the next slide and go into stage one in a bit more detail.
So thanks, Paul. So let's say I've got a clever piece of code. I've developed it. I'm a local tech startup, not a big pharma giant. Can I put this onto the App Store? I think we tried this before. Can I put this onto the App Store and sell into the NHS?
Well, if it was that easy, then wouldn't it be nice? No, stop right there, I think, is probably the message. In healthcare, it doesn't matter if you're a tech company. It matters really what your product does. This is about intended purpose.
Isn't my intention just to be cool and sell?
Well, I wish. Not specific enough, I'm afraid. Ask yourself, does it diagnose a disease, for example, monitor a vital sign, or treat an injury, or help treat an injury?
Well, the one I've developed scans for symptoms and suggests a diagnosis.
Yeah, okay. Well, then, strictly speaking, you are a medical device manufacturer, so you would fall under the medical device regulations for 2002, the UK version.
What is that?
Well, you're going to need, effectively, out of this, you're going to need a UK CA mark, and that's your safety stamp, if you like. And you must register with the MHRA before you sell a single unit. The Medical Health Organisation, authority.
So I'm fortunate enough to have a team of doctors helping me here, and they're reviewing the results for me.
Yeah, that would be good if you got a team of doctors doing so. But with that in mind, you would probably need the CQC too to look at that, the Care Quality Commission. So if you're providing care along with the tech, then you're going to get regulated twice, I think.
Yeah. So if I get this intended purpose definition wrong, I'm illegal?
Yeah, I think so. But exactly, your intended purpose isn't just marketing tax. It's really the anchor for your entire legal strategy.
Okay. So now I've got my intended purpose sorted. Can I just call them up and start selling my contract?
Not quite, no. Before you even look at your sales pitch, you need to look at the ticket to play again, as we referred to earlier, the DTAC, which is the Digital Technology Assessment Criteria. Think of it as the NHS's baseline checklist. It has 5 pillars. The first 4 are sort of a strict pass or fail. And it does sound like high pressure. And really, the first of these is clinical safety. You've got to comply with something called DCV 129, which is sort of setting out the clinical safety guidelines and what you should do and follow those. Then another one is information governance, or IG, and that's really, really important.
But isn't that just GDPR?
Yeah, it's more. It includes the data security and protection toolkit, which you'll find available from the NHS, a free tool to use, which is very, very informative and useful. There's also other tools that can be used, which I haven't quoted here, but public AI tools often cannot guarantee where data is processed. If data or patient data leaves the UK, then you will fail information governance. Certainly, the NHS like to have the data held in the UK, for example. That's one thing.
So if we're transparent and we said we use ChatGPT, would we be all right?
No, it's more. It includes the data security and protection toolkit, for example. Really, I think if you have an enterprise agreement that guarantees data retention and location, then you need technical security. So it's more than that, or the DSPT, or the data security protection toolkit that I mentioned before. Then you're going to need technical security, for example, like Cyber Essentials. Certainly you want to have Cyber Essentials at a minimum, and ideally Cyber Essentials Plus. Really to move to sorry, go on.
Yeah, I think that to an extent depends on the size of the company we're in, isn't it?
It does, absolutely. Yeah.
So I've been able to prove I'm safe and secure by going through all these checklists and getting my cyber.
Yeah.
Now can I sell it?
Not quite. I think the fifth pillar even is more of a curveball, I think. This is usability and accessibility. This one looks at a variety of different aspects of the usability and accessibility of the device, service, whatever that you're looking at. And this one is scored, so you've got to have a score on that too to get through. And you can pass all the security checks, but if you don't meet the accessibility standards, for example, there is lots of acronyms here, WCAG 2.2, which really covers about accessibility. For example, can a blind user use this screen, or if a poor sight, or that type of thing. So it lists and goes through those in quite a lot of detail. Then your score will drop.
If I've got a low score, does that mean I can't sell?
Well, potentially, yes. Yeah, it depends on what it is, or if there's a roadmap from you to go from A to B to improve within a certain time, that might be acceptable. But it's also worth noting that the consultation for things like DTAC we mentioned before, the Digital Technology Assessment Criteria, these are under review as well. And I think we will probably hear something next year about revisions to how that happens. So I think the message is really that this is an evolving compliance world, if you like, that we need to be aware of. But we expect that to launch sometime in 2026. But for today, we just stick with the current versions that we're working to, but be ready to move in the future as soon as we need to, or as soon as that becomes available. Yep.
Let's hope the AI bubble doesn't burst before we get there. So
Yeah, lots
let's
up for
go.
that. Yeah.
Yes, so let's go to our final step in our roadmap to sales, which is proving value and life cycle. So here we are. We built the AI. We've passed the safety checks. Now,
Yeah.
finally, can we just launch it and the NHS can pay us, right?
Yeah, I wish. Again, it's not that simple, Joey. In the NHS, you just can't claim it work. You have to prove it, which we kind of touched on earlier. Um,
Well,
yeah.
prove it. Like how? Like with Trustpilot reviews?
Well, it depends on the risk. For example, you use the NICE evidence standards framework. If your app just books appointments, for example, that will be tier A. Basic user feedback is fine. But if your AI is diagnosing a disease, then that's tier C. And I think,
What's tier C?
well, yeah, tier C, that means with clinical trials, you need to have hard data showing how it improves patient outcomes, or you won't get a CA mark ultimately, I think is probably where you need to have in mind. But
Okay,
it's,
tough but fair. So let's say I've gone through, got it, and got my CA mark. Now can I sell?
well, actually, that's the most dangerous time, really. I think it's not that easy yet. What happens is we've got something that's called post-market surveillance. Um, AI itself isn't static. If patient demographics change, your model, for example, can suffer algorithmic drift. Um,
Well,
which is
what's drift? That sounds quite bad.
Yeah, well, it is in a sense that if your accuracy drops, then you have to catch it immediately and report it to the MHRA. Even if you don't, you're non-compliant.
Oh,
Yeah.
okay. Thanks for that, Paul. So launch isn't the finish line.
No, in health tech, launch is just the starting gun, and I would just add that the post-market surveillance is a compulsory thing. You have to do this depending on the risk and the frequency that will be set out in your clinical safety plans and such like as you move forward. So very, very important to post-market surveillance and having that thought through properly.
Thanks. So we've covered so many different gaps now. We're compliant, we're safe, we're legal. Surely now, because that's all I want to do is sell it, surely now I can sell it.
Um, no. Again, Joey, I'm saying no a lot today, aren't I? If only. Procurement is where good tech goes to die if you don't speak their language, I think it's fair to say.
Well,
Um,
I'm a tech developer, like Python or C++.
uh,
What?
no. Value, I think, is what we're talking about here. You need to give procurement team the four things in specific order. For example, so we look at the diagram, we're looking really, the safety, the IG, the evidence, and the value.
Okay,
Yeah.
so we've covered safety and IG quite well, I think. So what does deployment part mean?
Well, that means you've got to make the life easy. You've done the element we call DCB 129, which is the clinical safety part, working through all of the clinical safety file, building up the case and so on for your safety. You've got to hand over the data to the trust that wants to buy that, and they will do, if you like, their equivalent check on that, which is using a similar set of guidelines, but something called slightly differently, which is the DCB 160. Sorry, apologies for all these acronyms, but it's littered with them. But if you don't help them with the paperwork, they won't sign yours, basically. So, it's a two-way thing. You've got to
Okay,
work
so
to get that.
we meet them halfway. We help them deploy, and this value part business.
Yeah, and that's critical. Don't just say we save time. You need to define it. Is it cash releasing? Does it save actual budget? Is it capacity releasing, freeing up doctor to see more patients and in turn, saving funds that way?
Oh, I'd like to bring us back. What's this secure data environment thing? We mentioned it before, but what's this?
Yeah, the NHS is moving data into secure vaults. If your AI can't operate inside a secure data environment, you might be locked out for the future. So it's important.
So in summary then, safety gets me in, but value gets me the contract.
Yeah, exactly. Yeah, that's fair to say.
Okay, thank you. So this, I think, brings us to our penultimate slide. So we're trying to summarize everything that we've spoken about. This is our, I think, Paul, we've intended this to be the master plan. Looks like a lot, but I can see the path now. Can you take me through it?
Yeah, it is a path, and just notice the order really, Joey. I think it's preparation. I think preparation first, define the intended use, get the DSPT that we mentioned before, the Data Security Protection Toolkit, which is free and available on the NHS, and safety done early. And I think don't build.
Okay. Oh, go on. Sorry, go on, Paul.
Yeah, sorry. Yeah, don't build tech, and then try to bolt on safety later. Then evidence, check the NICE tiers, which are available again all online. We provide some references in the slide deck later, so you'll be able to pick them up at your leisure. But don't overpromise.
And this, we've talked about secure data environment. So what's the strategy for this then?
Yeah, you need to be ready to bring the AI to the data and not them to send the data to you. So you need to be able to take it into that secure data environment. Yeah, it's very important.
Okay.
Yeah.
So if I tick these boxes, safety, information governance, evidence, and get access to a secure data environment, then I'm finally ready. So I'm just not pitching a product. I'm handing a procurement a solution that they're legally allowed to buy. Is that right?
Yeah, but don't pitch until you can tick every box, really, I think, Joey. But yeah, I think that's probably covered what we wanted to deliver today, I think. Is that right, Joey? Have you got anything else you wanted to
I think
add
so.
on?
I think so, actually, Paul. Where have I gone? I'll just stop sharing. And I think we've covered everything that we want to cover in our presentation. And now we'd just like to open up the floor to some questions, if there are any.
Apologies, we seem to have talked a lot. A lot of information
Hi,
there.
both. Thanks very much for that. There is one in the chat at the moment, and it's from Deep Sharma. It says, I'm not sure if this is the right space for it during a session, but we're going to go with the question anyway. He'd love to connect further because they're building what they believe is the first global patient companion platform. And recently submitted innovation for proposal for the NHS. He's keen to understand how he can move forward. But this is probably something he can take offline with himself. Could you give him some sort of guidance maybe and support the startups on how they can engage the right conversation to explore? It's probably one that you might want to pick up with Deep by himself. So I think his email address will be in there. I think he's just typing at the moment.
Andy, can I just respond to that? That's something that, well, his question is actually quite pertinent, and we can pick it up as part of what we do. We have a consulting service, and feel free to ask questions and pick our brains. At the moment, we're just working with a professor in the University of Birmingham who's trying to work out how to set up an app that he's created under the university's auspices and under a research grant, and move it into a commercial world. So everything we've talked about here, we're going to undertake as a journey with this professor to get his legal entity, his limited company, and his procurement process all set up. So it's actually, feel free to call us. We can take you through any of those things. Hopefully you've seen in our personalities, we're quite chatty, and we try and break things down so it's not technical, though we do have some of the technical expertise behind us.
There's anybody from the you can either, I think, drop into the chat there any questions, or if you can raise a hand. I'm just trying to see if I need to unmute everybody if needed, but nothing else is coming through at the moment. Any questions? I'll just do it.
It's like
unmute yourself. You can unmute yourself everywhere. I think I've just done that. So if you do want a question, please unmute and ask.
It's a bit like one of those interminable Teams meetings in the NHS. Actually, everyone puts themselves on blank and mute, and then goes off and makes a cup of tea.
No. We've got, hang on, there's one just being typed in. I don't know if you can see the chat as well, Joe and Paul.
Just is that Holly just about to type?
Yeah,
something?
Holly's just chatting, just putting in the chat at the moment, typing. So we'll just give that a second. There's a question there. Most startups are not having full compliances and tick mark. How does the NHS look at this? That's from Deep Sharma.
It's one of those. It depends. Most of the time, you won't be able to sell completely. What you might be able to do, depending on how much you've got as compliance, is find a friendly clinician, someone who's going to champion you, unless you are one yourself. And then you've got an in which case the in is to try and do a pilot. And what we found is that no one in the NHS wants to pay, full stop. No doctor will say, oh, yes, and I'll cough up for it. What they will do is say, oh, okay, I'll run it as part of my clinical program. And if you want to give it for me, free for me for a period, then I'll consider it. Once you've got that in, then the bit you need to show is that whilst they run that pilot, your product is safe and secure. So the information governance side and the cyber essentials side, etc. You need to have that, and you might be then able to work with the doctor to get the clinical safety. So that would be the sequence of work.
Okay, so Holly's question is: With the UK likely to move forward towards, allowing the EU MDR/CE marking for medical devices, should we still be looking to follow the UK MDR 2002 for the UK CA marking?
Good question, Holly. I was having this discussion with a UK CA certifier this morning. So today it's the UK MDR, and there's some brilliant acronyms called the NBOG codings. So if anyone's been involved in that, it's just the way that the device or the software is categorized. The drift in towards EU at the moment hasn't been formally agreed. It's been signposted. So until actually that cuts across, there's not that much difference between them. It's mainly the coding numbers, UK versus EU, and then what the numbers mean. Are you a device? Are you in vitro? Do you have an implant, etc.? So the UK ones basically were spun out of Brexit. And if we do revert back to or align back to the EU ones, we haven't actually diverged that much in the meantime.
Yep.
Good. And there's another question being typed up at the second.
Oh, there was another question from Deep. It says, could you guide me on how the NHS supports startups and how we can engage in conversations to explore collaboration? Deep, actually, that's a good question to ask someone like Andy, who represents Health Innovation West Midlands. So there's a whole ecosystem of incubators, startups, accelerators, etc., which are funded, public body funded by the NHS. So Health Innovation is an example of one of those, where they'll take you through everything that's not tech almost. So you're in terms of trying to how to understand unless you're a clinician, how collaboration within the NHS works, how clinical trials and pilots work inside. So that adoption process that we covered earlier, these guys will be able to help you with that.
Yeah, we've picked up actually as well, Joey. So I've met Deep and his colleagues. So we've started that ball rolling from our side. So Andy,
Thank you, Andy, for that.
We can hi Deep, no worries. Yeah, so Deep, we can connect. You can connect with Joey and Paul. We can connect you via email after this. So it's not an issue. So we'll do that.
Sure. Thank you. Thank you, Andy.
No worries. Are there any more questions? I believe I have opened it up so that you can unmute and ask a question if you want to, or you can put it in the chat. Is there anything from Joey or Paul? Is there anything else you want to add?
I think we mentioned it a couple of times. This whole space is that AI and the regulation of AI is a little bit like the Wild West. It depends on what you can get away with. That's on developing something. And the NHS is, if you're wanting to sell in, is astonishingly risk averse. So it's the Wild West in development and trying to create something that's a tool or something that's useful. And then suddenly you enter like the death zone of people who are not clinicians, but are procurement or information governance, etc. And the biggest thing to be cognizant of, really, is the NHS is completely underfunded. So when you try and get in, you are at the end of a very long queue of people also trying to get in, and some of whom have much deeper pockets. So going through the thought process of preparing yourself for the checklist that the NHS ask you of what is the wrapper of your company and how does it provide value, as opposed to how good is your product and does it work, is something that if you start thinking about that as you develop your product, it's a lot easier because you lay those foundations down the first time and you don't go back and have to rework them because you don't know how to answer a particular question they've asked, and you have to build that back into your system. I think that's what we found in helping our clients is think it through and get it right, generally by following the checklist the first time, rather than have to dig everything back up and rework your code, so that you can put the evidence together and demonstrate it on an ongoing basis. Is that selling is day one, that's the hardest bit, but then the ongoing performance and monitoring through the life cycle of your contract, you will need all those foundational blocks in place in your code and in your system to provide the evidence for you to carry on.
Yeah. I think it's also worth adding that, Joey and everybody, that the AI itself and the regulation is evolving. There is more information coming out. There's, for example, I think at the University of Birmingham is quite close to the development and sort of progression of AI regulation, with lots of inputs going on. There's a team set up there to sort of deal with that, and I think they're probably very, very key in what that development would be, and we try and keep abreast of what's changing. So next year you can expect some differences and some moves in the requirements and how things are assessed, the ethical reflections, templates, and all of the things that people may be using, what their expectations are. So we need to just keep tuned in, really, I think is the message. But that's our job, I guess. Yeah. Well, come to us if you want to find a bit more information. Yeah.
We have 2 minutes left on the clock, so to speak. If there's anybody that has a final question that they wants to ask, please feel free to ask that now. Likewise, Joey, Paul, if there's anything you would like to say before we finished. Oh, hang on. Holly, you mentioned that in engaging with the CQC is essential alongside MHRA registration. Would you recommend early engagement with CQC when developing AI tech?
Holly, hi. It depends on whether you've got, I think we mentioned, if your product provide, or if your service provides care as well as diagnostics. So if we say the AI is used to provide the diagnostic and the judgment and the decision, the wrapper of your service, does it also provide care? And if that care is provided by someone who's clinical, and if that's the case, then yes, engage with the CQC. But if it's just if your product is an AI-based bit of software that causes clinicians in the hospital to provide care, then no, you won't need to. If you provide some of those clinicians, then yes, you'll need to provide the CQC. Work with the CQC. Does that answer your question, Holly? That's good. Oh, thank you, Shireen.
I think, yep, that's it for those. So I just want to bring it to a close. Joey and Paul, thank you very much again for once again another interactive and insightful webinar, and we'll look forward to doing another one going forward into 2026. And thank you everybody for joining. And if you want to reach out, then please email across and we'll get in touch. Thank you very much.
I think the slides will be sent out too, Andy. I think it's worth saying.
The slides sent out. Lovely. Cheers.
Yeah, we'll drop you a copy of the slides afterwards. Yeah. Okay.
Lovely. Thank you, everybody.
Thanks everybody for joining. Thank you.
Thank you.
Thanks, Andy.